All right, so next up in our Learn to Swim mnemonic is Ewing Sarcoma. Ewing Sarcoma is a tumor that's predominantly occurs in Caucasians. Peak age is around 20, but the age range is quite wide. Most of these cases are going to happen between about age 5 and somewhere in the 30s, but you can certainly see these in infants, and you can see cases into the 7th and 8th decade of life. This is a diaphyseal bone tumor, most commonly. That means it's in the center of the bone, so the ends of the bone are the epiphysis. Next is the metaphysis, and the middle is the diaphysis. So these are diaphyseal bone tumors, but you can also see them in solid organs like the kidney and other soft tissue locations. And the real clue to what these are histologically is that they're very, very monotonous. That's true of a lot of things that are driven by fusions, and Ewing sarcoma is driven by a fusion, so it's very monotonous. And the foamy cytoplasm is really, really helpful in identifying these. You can also see calcifications mixed into these as well. So the differential is really with synovial sarcoma, which can also be a very round cell tumor and present in a lot of places when it's in a soft tissue location. Desmoplastic small round cell tumor in soft tissue locations. And of course, when you're thinking about the kidney in kids, you want to think about Wilms tumor. Also, we talked about lymphoblastic lymphoma and why that's in the differential. I think the other thing to think about here is other types of bone tumors like the B-core altered sarcomas that we'll talk about a little later. So most Ewing sarcomas, about 95%, are going to have a translocation that involves EWSR1. They're going to be positive for CD99, and my favorite marker is NKX2.2 because it's a nuclear, it's very clean. But hopefully when we're done with this, you'll understand that there's a lot of pitfalls around EWSR1 translocations, not only with other sarcomas, but with other tumors in general as well. So I said this was a diaphyseal bone tumor. Here's a really good picture. This is actually from a YouTube video I posted on grossing bone tumors. And what you can see here is this is a long bone. It's the central portion of the bone. The surgeon has cut the ends off to take this out. And you can see here's the cortical bone, and here's this large mix of tumor and periosteal reaction that's infiltrating through the center of the bone. So this is a diaphyseal tumor. It's happening in the middle of the long bones. That can be the femur, that can be the humerus, that can be the rib. If it's middle of the rib, it's actually going to be lateral, and that's something you may hear referred to as Askin tumor. But they're almost always going to occur in the diaphyseal. They're going to occur in diaphyseal locations, almost always in long bones. Occasionally, you'll see them in flat bones like the skull. So here's my touch prep. I love doing touch preps on these, and right away you can see this is more cohesive. You're seeing cells that are a little piled up on top of each other compared to that lymphoma we looked at. And at high power, you can see you have this very, very homogeneous, very fine chromatin, very immature looking cells. And some of these have a lot of abundant kind of pale cytoplasm. A lot of these, the cytoplasm is kind of broken open and spilled onto the slide. So you might see a tigroid background because a lot of what's in the cytoplasm of these, if you ever look at them by electron microscopy, most of that cytoplasm is actually glycogen. So you're going to see that in the background sometimes. In a histologic section, what you see right away is this is pretty blue, but there's a lot of these spaces for large vascular channels, and there's some necrosis here. There's some calcifications here as well. So you can see these pretty broad fibrovascular cores in this example, as well as that necrosis and some calcification. Now, this is a really good look at the typical histology of these. Again, you can see the nuclei are round to oval, very monotonous. And that cytoplasm this is a pretty typical cytoplasm. It's kind of frothy, kind of clear, but you can actually see a pretty big range from completely clear to more pink. What's really helpful, I think, is the nuclear cytology. And also, if you'll notice in the background, there's a number of these darker kind of angular cells that are generally at the edges of the nests, maybe even along vessels. David Parham taught me this. If you can identify these cells, that is a really great tip-off that this is a Ewing sarcoma. You don't see those cells in a whole lot of other things. So this combination of that cytology that's very monotonous with the foamy cytoplasm and these darker angular nuclei always gets Ewing to the top of my differential when I see something like this. Now, immunostain-wise, CD99 is the kind of prototypical stain. If you have a tumor that looks like that and stains like this with CD99, you're going to call this Ewing sarcoma all the time. And when I say stains like this with CD99, what do I mean? This looks like stained glass. Very solid, contiguous CD99 reactivity around all these cells throughout the whole tumor. If you don't see this, if you see something that looks patchy, that's when you're going to think about other tumors, other sarcomas that have maybe even an EWSR1 translocation, but have a different partner that make them something other than Ewing sarcoma. And of course, my favorite marker is NKX 2.2, pretty sensitive, pretty specific, nice nuclear marker, so very clean. And this is really good marker for Ewing sarcoma that has the EWSR1 Fly1 translocations. And we'll talk a little bit about about the molecularly defined classification later. All right, so this is my reminder to pause here, take a breath, and we're going to come back to the molecular features of Ewing sarcoma after this slide. I'm just going to check the chat real quick. I don't see anything, no questions yet, but feel free to drop those in as we go. I'll answer them as we go through this. So this is the previous classification from the WHO, Ewing sarcoma and Ewing-like sarcoma. This is no longer the current terminology. And what's changed is that many of these fusions, as particularly the CIC DUX4, have now dropped out into their own categories. So this is what the current WHO looks like. Let me get out of the way here. So the current WHO breaks these up into 4 groups. Ewing sarcoma, which is going to have an EWSR1 Fly1 translocation in the great majority of cases, about 85% of the time. And then another 10% of these cases are going to have an EWSR1 ERG fusion. That's going to give you about 95% of all Ewing sarcoma is going to have one of those 2 fusions. The rest are going to be EWSR1 or FUS fused to an ETS transcription factor family member. And so this is the major split in these 2 groups on the left. The round cell sarcomas with EWSR1 fusions and partners that are not ETS family members, they have now split off into their own group. So you have EWSR1 with NFAT-C2, FUS with NFAT-C2, EWSR1 with PAT-Z1. These are now their own category. Also in their own category now are the CIC rearranged sarcomas. And we'll talk about CIC rearranged sarcomas at the end of the talk as one of the molecularly defined entities. The vast majority of these are going to have CIC DUX4. They're now considered a distinct entity from Ewing sarcoma, and I think with good reason. And lastly, sarcoma with B-core genetic alterations. This can either be fusions that involve B-core, often with CCNB3, or B-core internal tandem duplications. Interestingly, those tend to be in infants. And also interesting to this group is that the YWHAE fusions with NUT-M2B are in this category because that fusion actually upregulates B-core. So it's part of the same family as the rest of these. Now, I mentioned earlier that I wanted to talk a little bit about the pitfalls of EWSR1. So here's the list, and again, something else I'll put on social media. Here's the list of things that have EWSR1 fusions that are not Ewing sarcoma, and it's pretty long, and some of them are histologically similar, like desmoplastic small round cell tumor that we'll talk about, and obviously some of them are histologically quite divergent, like myxoid liposarcoma. So know that there's some limitations to doing things like EWSR1 FISH. All right, so Ewing sarcoma is a diaphyseal bone tumor. You're going to want to look for that really foamy cytoplasm, that really monotonous nuclei, and that population of smaller angular cells. There's limitations to CD99. When it's really strong and completely solid around all the cells, you feel really good about calling that a Ewing sarcoma without even molecular testing. And of course, EWSR1, if you just did FISH, there's a lot of pitfalls there.